Hello, everyone, and welcome to our program today about genetic testing helps determine your risk for prostate cancer. Most people think of genetics as determining your color of your eyes and your complexion and how you may talk and other physical characteristics that we see, how tall or short you are. But it goes deeper than that. And tonight we're going to talk about genetic testing and prostate cancer. My name is Thomas Farrington. I am the president and founder of the Prostate Health Education Network. I welcome all of our viewers tonight. I want to thank you for joining us. I want to thank our sponsors for being with us and supporting this program that we may bring it to our viewers. So thank you all. Thank you, our viewers. Thank you, our sponsors. We're very excited about this program this evening. What I would like to say is that anytime during the presentation, any part of the presentation, feel free to pose a question into the Q&A box. We will hold that question until the end of our program when we will address all of our questions. Also, at the end of the program, you will see a survey box, and we would love to get your input on how you feel we did, what you were able to learn from this program tonight. So please, I ask you to take time to answer the quick survey, which will be no more than just 4 or 5 minutes, and it is anonymous. So you can feel free to say you did great or you didn't do so great, but we just would love to get that feedback from you. It helps us to make sure that we bring the best that we possibly can to you, our viewers. So at this point during our program, I would like to introduce Dr. Keith Crawford. Dr. Crawford is our Director of Clinical Trials and Patient Education. Dr. Crawford will begin with a presentation, after which he will introduce our guest speaker. So Dr. Crawford, I'm pleased to turn this program over to you.
Thank you, Tom. And thank you to the audience for attending again our monthly webcast. I hope you will enjoy it and get some information from it. So give me a second and I'll share my slides. And as Tom has mentioned, the topic for this evening is genetic testing helps determine your risk for prostate cancer. Now, this evening, we'll divide it up into 3 different categories. We'll get a genetic overview. We'll hear from our speaker, Justin Lawrence, and then we'll have questions and discussions about what we've discovered today. So under genetics and overview, normally we give you a genetic vocabulary, something that you can get familiar with. These are terms and words that you will hear throughout the presentation. I want you to understand the benefits of genetic testing, the guidelines for germline testing in prostate cancer. Also, what is somatic testing? And why is genetic testing important for Black men? So as you know, I like to show pictures, but we want to bring it down to its simplest level. So when we're thinking of DNA, I want you to think of DNA in your body, in your cells, just like a cookbook. And in this cookbook, you have recipes. So in the case of DNA, instead of recipes, you have genes. Now, these recipes tell you what the combination of, whether it's flour or sugar or eggs and milk combination that you need. The amino acids are what help you construct the final output. In this case, I like peach cobbler, so we're making a peach cobbler, even though I have some cupcakes up here. But in this case, the whole concept here is this. Let's go back to the fact that in DNA, you may have mutations. So you think about these mutations the way you think about typos in the document that you've created or someone's created. And also think about correcting these typos by having a spell check mechanism. In this case, the cells have its own unique mechanism of correcting. Next, also, when we start talking about genetics, I want to bring everybody back and we talk about the chromosomes, and we have 23 chromosomes, and the chromosomes are made up of DNA. Now, these long strands of DNA. And then as you go down a little further, The DNA is made up of genes. So remember, when we think about genetics, this is scientific study of genes and heredity and how certain qualities or traits are passed on from your parents to children as a result of changes in the DNA sequence. So now, and genes are just a segment of DNA that contains the instructions. Like I said before, it's like that recipe for building one or more molecules that help your body work. Now, some words that you'll hear throughout the presentation with me and with Justin, and germline mutation. And what we want people to understand, when you hear this germline, I want you to think of genes and lineage. Now, their germline mutations are gene changes in your body, and they normally take place in those cells, the reproductive cells of the body, the egg and the sperm, and they're incorporated into the DNA of all the cells of the body. So germline mutations are found in all the cells of the body, and they're passed on from the parent to the children. Now, germline mutation testing can help assess one's risk for prostate cancer. Somatic mutation, on the other hand, is a gene change which occurs in a single cell and only affects the new cells that are created from that mutated cell. Remember, somatic cells do not pass on this mutation to the children. And somatic assessment or somatic testing examines the genes in the prostate cancer specimen to help determine the line of treatment. Now, you'll hear about PARP proteins, and these are proteins that are normally found in the cancerous cell and are responsible for DNA damage repair. But what happens if you have a molecule or a therapy that interferes with damaged DNA repair? There's a class of drugs called PARP inhibitors that prevent these PARP proteins from repairing the DNA damage. Now, this weakens the cancer cell, making it more susceptible to chemotherapy or other treatment options. All of this rolls down to one thing. We're moving to an era of personalized cancer care. And in doing so and knowing this is why it's important for you to understand and know your genetic information, because this will better help you manage your prostate cancer. Another way to look at this, again, germline mutations, genes, lines, lineage. So that means that this is information that's inherited and passed on to your children. Now, 10% of prostate cancer is inherited. Genetic tests assess one's risk for prostate cancer. Somatic mutation, on the other hand, the DNA mutates, but it's not passed to the children. 90% of prostate cancer is from somatic mutation. So genomic testing examines genes and helps predict the prostate cancer behavior. Now, what are the benefits? There are numerous advantages of if you know what genetic mutation and how it links to prostate cancer. So from an individual perspective, you can individually screen. So now you may wish to undergo prostate cancer screening, and it may start at an early age, even if you have no family history. But if you're an African American, normally we're at high risk. So one would suspect that we may want to think about individual screening because we're high risk. Now, but you think about it, just because you may have the gene, do you think your family members could have it? Because remember, certain genes are transferred over, or mutations are transferred over from family members, from parent to child. So even though you may have a BRCA mutation, but your female members of your family may have the same mutation, but that would put them at risk for breast cancer or ovarian cancer. So this is why it's important not to just think about the impact on yourself, but also on family members. Genetic testing can help predict how aggressive prostate cancer might behave and how likely it is to advance or metastasize. And again, we're moving into this precision medicine era where you can individualize or customize your treatment therapies. Term inherited genetics now significantly increases the risk of prostate cancer and may be associated with aggressive disease. So I say it again. These risks, genetic mutations, may be associated with aggressive disease and poor outcomes. And these hereditary information can have implications for other men in your family, as well as other family members. Germline genetic testing. Again, I repeat it. Germline, you're thinking genes, you're thinking of something that's passed on to your children and from a parent. And it is now strongly recommended that patients with advanced metastatic prostate cancer, particularly given the impact on targeted therapies, or clinical trial options, should think about genetic testing. Now, all patients with metastatic or high risk or very high risk localized disease should be tested for genes. Now, there are in this case, about 8 particular genes. And I want to highlight BRCA1 and BRCA2. Now, you may have heard these names, but just for your understanding, BRCA, BR is breast, and CA stands for cancer. So it's cancer gene 1, breast cancer gene 1, and breast cancer gene 2. That's what we'll focus on today. Now, genetic counselors may suggest testing these additional genes. And in this case, this is HOXB13, which is very interesting, and we may talk about it later. But it's commonly found in people in the earlier stage of disease. So for Black men who have a high incidence of contracting or developing prostate cancer in their 40s, it may be important for this gene to be assessed. Now, there's something that your clinicians or your genetic counselor will talk about is this risk, this BRCA1, BRCA2 risk. So it's called a familial high risk assessment and to determine whether or not you should have BRCA testing. So men with metastatic prostate cancer, men with a Gleason score greater than 7, who have at least one close relative with ovarian, pancreas, or metastatic prostate cancer or breast cancer at or less the age of 50. Now, you see what I'm saying here is you don't necessarily have to have someone in your family who has prostate cancer. You may have an aunt or a sister who has ovarian. You may have somebody who has pancreatic cancer or breast cancer. So it's very important. The other, 2 or more close relatives with breast cancer or prostate cancer at any age, on Ashkenazi Jewish ancestry. And important, prostate cancer screening recommendations include starting at age 40 for BRCA1 or BRCA2 carriers. Now, we've talked about this inherited component. Now let's talk about somatic testing for prostate cancer. Just to hear it again, somatic mutations are not inherited. Now, what's interesting, they can change over time. And that's why it's very important even though you've been tested one time, a doctor, your healthcare provider, may want to test it again to see if there's been a change in the overall genetic makeup of that cancer. Now, somatic testing help determine what your treatment options are, because now we have treatment options. PARP inhibitors, I mentioned earlier, immunotherapies are been associated with gene changes. And we have clinical trials like Amplitude that have determined your eligibility to proceed further in the clinical trial. Now, you may hear, or you may have already heard something called NGS, there's next generation sequencing. This next generation sequencing is a much more detailed sequencing. It allows you to look for specific gene pathways, whether it's antigen receptor amplification or any other pathways that may be associated with genes. Now, what about the source? When we start talking about somatic testing of prostate cancer, the source is different. Now, genetic testing, you can get it from the blood, you can get it from sputum, and you can also get it from the urine. Now, the source for somatic testing is they target primarily the tumor resection. So they may get an old tumor specimen and look, or they have to biopsy your cancer again to get that information. Now, what's interesting here is they also can look for something called circulating tumor DNA. And that's DNA that's specifically from that tumor that's found in the blood. I've mentioned before, once you have this genetic information, now you can use this to better manage your cancer. Now, on the right side, left side here, across the top, I'm going to cover like genes, those that have an increased risk, other cancers that are associated with these genes, and that there are combination therapies like PARP inhibitors plus a chemotherapy, immunotherapy, and also preventive screening. So these 8 genes, if you follow the check marks, but again, we're focusing on these BRCA1 and BRCA2, but these other 4 genes here can play a role in your management. But the first 2 are important. And I just want to highlight again, you may have BRCA1. This increases your risk, but it could increase the risk of someone in your family to have breast, ovarian, or pancreatic. So again, you can use genetic testing to help not only manage the treatment that's available. Now, do you want PARP versus a chemotherapy, PARP inhibitor versus chemotherapy, or immunotherapy, immuno-oncology based therapies? So that's kind of the take-home message there. You can screen, be preventive and predictive, or you could better manage your treatment. So the question is, why should Black men get genetically tested? That's your big question. I mean, we know Black men are known to have an increased risk of being diagnosed and dying from prostate cancer. Now, Black men are more likely than Caucasian American or Asian American counterparts to have a broad range of genetic changes that increase the risk of developing prostate cancer. Genetic testing is beneficial for identifying Black men with metastatic castration-resistant prostate cancer who could benefit from these new therapies. And remember, we're talking about these mutations, BRCA1, BRCA2. Now we can determine who's eligible to use these because the FDA in 2020 approved rucaparib and olaparib, these 2 therapies for the treatment of metastatic castration-resistant prostate cancer. Now, there exists, and this is what a lot of people don't understand, and this is why PHEN is pushing this. We recognize that there's a disparity that exists when it comes to Black men and prostate cancer. And this is a large racial disparity. What's interesting is this, and this is what we want to emphasize. Prostate cancer, one, is highly inheritable disease. Now, this is a large disparity that exists across racial and ethnic groups. African-American men are at increased risk of being diagnosed and dying from prostate cancer. Prostate cancer incidence varies across racial groups and is approximately 75% higher in African-American men, but 45% lower in African and Asian American men when you compare that to Caucasian men or non-Hispanic white men. Very important. So now you're starting to see this disparity, the difference genetically and how the disease behaves. African-American men are more likely than their Caucasian or Asian counterparts to have a range of genetic changes that increases their risk for developing prostate cancer. Now, we know that age, family history of prostate cancer, and germline mutations are the most established risk factors for prostate cancer. But did you know over 50%, 57% of this variability in prostate cancer risk is estimated to be due to genetic factors, these genetic mutations, these genetic changes. So we hypothesize, like others, that genetic factors may contribute to this disparity in African-American men when it comes to prostate cancer. You may ask, well, then why should Black men participate in clinical trials? And this is to point out the human genome. We sequenced all the genes of the body. It finished in 2003. And from 2003 to 2022, almost 19 years, we have been able to identify these cancer risk locations. But the problem is a lot of the research have been done on people of European ancestry, about greater than 80%. And then next in line for these risk locations in the body are those people of Asian ancestry, East Asian ancestry. And then there's a collection of multi-ethnic data points that exist. But African-American and Latin Americans only have about 1% of this information from them. And this is just a drive point, is that this is why Black men need to participate in clinical trial research. So let us begin to stop closing this gap. So our takeaway, germline mutations are gene changes found in every cell in your body and are passed on from parent to child. Germline, passed on from parent to child. Somatic mutation are gene changes which are restricted to a single cell and are not passed on to their children. PARP inhibitors are a class of drugs that prevent PARP proteins from repairing the DNA damage and weakens the cancer cell, making it more susceptible to chemotherapy, immunotherapy, and other treatment options. Men with metastatic castration-resistant prostate cancer who have BRCA1 or BRCA2 mutations may be eligible for treatment with PARP inhibitors. And just remember, I'm not going to give you all the genes, but there are other mutated genes that you need to be aware of that may make you eligible for some of these new therapies. And lastly, Black men are more likely than Caucasian or their Asian counterparts to have a range of genetic changes that increase their risk of developing prostate cancer. Now, that's a lot of information, but that's a lot of information to digest. But that's why it's important for us to kind of bring on a specialist. And that's why there's a genetic counselor. The genetic counselor is a person who's responsible for helping guide you through this difficult testing and better understanding how genes impact your disease. Now, Justin Lorenz, he's a genetic counselor from Sunnybrook Odette Cancer Center. Now, I'm going to hand this off to him because he's going to take everything that I take, all this complicated information that I gave you, and he's going to take it from there. Justin?
Thank you so much, Dr. Crawford. That was a brilliant presentation. It was, I feel like a little intimidated speaking after you. I thought you did an excellent job, and you really kind of narrowed down some really challenging concepts. I think that this format of having you go through some of these terms, I've never really seen it being done before, and I think that it's a brilliant way of increasing exposure and confidence to this type of really technical information. And so thank you very much for that. It's my pleasure to speak to you today. I'm a genetic counselor, and I'm speaking on behalf of Promise, which is a registry. And another kind of term, I guess, to throw out there is this term registry, which essentially is a group of individuals who are being studied. And this group shares something in common. And in the case of this PROMIS registry, there's actually two things that men share in common. One, they're individuals who have prostate cancer, and two, they have one of these genetic predispositions to prostate cancer. They have a gene mutation that was identified, and this gene mutation is either known to be associated with prostate cancer or it's potentially associated with prostate cancer. And so these are the men that we follow. And to kind of piggyback onto the last of Dr. Crawford's slides, representation in research is incredibly important. We understand there's a huge discrepancy in research done on individuals of Caucasian ancestry versus men of African American ancestry, and as a result, programs want to kind of decrease that divide, and so getting individuals to participate in research will help us answer questions that can be meaningful to everybody. A lot of the research that we do, certain genes are just found in individuals of Caucasian ancestry. If we do more research in Black men, we may find these exact, or different variants that are just present in the Black community. We'll never know that unless we do lots of research with big groups of men who are involved. So our team, I noticed one of the sponsors for this talk is ACT, or Advancing Cancer Treatment. We also work with Prostate Cancer Clinical Trials Consortium. And Dr. Crawford also mentioned a bunch of different genetic testing criteria. We simplify it. As part of our registry, any man who chooses to be a part of this gets access to genetic testing, looking at 19 different cancer-related genes, including the 8 that Dr. Crawford discussed. And we do that through testing through a genetic testing company called Color. In terms of the individuals, Dr. Heather Chang from the University of Washington, Dr. Channing Poller from Johns Hopkins University, myself, I'm a genetic counselor from Toronto. I'm based out of a hospital called Sunnybrook. And then Jake Vinson, who's the CEO of Prostate Cancer Clinical Trials Consortium. So we are some of the people involved in PROMIS, and together we're all kind of hoping to get this insight from individuals who have genetic mutations in order to help facilitate research. So today, what I want to talk about are genes, cancer risk, how genes impact cancer. I want to talk about genetic testing, and I typically just save the word PARP for later on, but PARP inhibitors are kind of one aspect of how management can be changed based on genetics. But even whether or not someone pursues surgery versus radiation versus active surveillance, genes can help clinicians make these decisions. I want to talk a little more about what PROMIS is as a registry, and then we'll save some time for questions and discussion. So why your genes matter? Really, genes are essentially very long pieces of DNA. Each gene has a job, and as described, the job can be, dictating height, eye color. It can be associated with a myriad of different things. But really, when it comes to the world of cancer, I'm interested in the genes that protect us from cancer. I call them cancer protecting genes. Everybody has these genes. In most people, these genes are working great, and they are doing their job of protecting us from cancer. Some individuals have mistakes or mutations in these genes. Mutations, also mistakes, to go to Dr. Crawford's analogy, are typos. And mutations, most of the time, are acquired throughout our existence. There's 20,000, or there's billions of cells that make people. And as we, as a mass of cells, walk through life over the years, we get exposed to UV radiation. We get exposed to chemical exposures through smoking, through pollution in the environment. And these changes can modify the DNA in our lung cells, in our skin cells, in our eye cells, in our prostate cells. And these healthy cells that used to have perfect genes with no typos or mutations may start over time collecting some gene mistakes and mutations. As cells divide and grow, there could be mistakes and mutations that occur there. It's like taking a piece of paper and photocopying it 1,000 times. By the 1,000th copy, there might be some buzzed out areas that are unclear. Mutations occur by random chance. And so if you compare the mutations in all the cells of a little baby to that of an 80-year-old, and we take a skin sample, I can tell you, the skin sample of that baby, those cells are going to be perfectly, great with no mistakes or mutations. The skin sample of an 80-year-old, they're going to have 80 years worth of mutation accumulation in those skin cells. Some mutations are also just inherited from mom, from dad's sperm, from mom's egg. There may be a mistake or mutation in the egg or the sperm. Well, when that sperm fertilizes that egg, boom, we have a pre-embryo that is born with a gene mutation. If that's in a cancer-related gene, then that person's going to have a genetic predisposition to cancer. People say, all cancer is genetic, and it's really true. Really, what cancer is when one healthy cell acquires mutations in cancer-related genes, and then it starts to deviate from being its healthy cell. If it's a prostate cell that was once healthy, it accumulates a mistake or mutation, it stops acting like a team player with all the neighboring prostate cells, it starts becoming more selfish. It starts dividing on its own, not in the steady rate that you'd expect prostate cells to grow in. The cells will then accumulate more mistakes or mutations, and then it might turn into a lump or a tumor. And that tumor, there might be some more mutations that occur within that tumor, and it gets bigger. It starts taking up resources from that part of the body. Maybe some of those cells that are so mutated, they forgot that they're even prostate cells at all, will move to other parts of the body. That's called metastasizing. So cancer essentially is when a healthy cell accumulates genetic mutations and starts evolving into a different type of cell that's kind of gone rogue. So with respect to the gene mutations, and I think Dr. Crawford did a really good job in explaining the difference between these somatic and germline, I want to kind of further illustrate this concept of how we can inherit these gene mistakes or gene mutations. So most mutations happen by chance, happen by bad luck, happen through radiation or chemical exposure. But when it comes to the world of cancer, 10% of cancers are started off because of some gene mutation that was inherited. 10% of cancers are due to some kind of an inherited genetic, already predetermined risk. So what I have here is an example. I have a woman and a man, dictated by those icons up there. And then under the woman, there's 2 copies of a gene. Now we get 1 copy of our genes from mom's egg, the other copy of our genes from dad's sperm. So we have 2 copies of every gene. And for her, both copies are working just fine. For the man, 1 copy is just fine, but the other copy has this red patch on it. And I'm going to say that's a mutation. So 1 copy of his genes has a mutation in it. Now let's say these are cancer protecting genes. This man has a mutation in 1 copy of his gene, and he's genetically predisposed to cancer because of that, because he has this mistake or mutation in the cancer protecting gene. Now, when they go on to have kids, mom's going to pass on either 1 copy of her genes or the other. It's a 50-50, but it doesn't matter. Both of her copies are working just fine. Dad, however, he's going to pass on 1 copy or the other. However, 1 copy and half of his sperm is going to have a mutation, but the other copy and the other half of the sperm is not. It's a 50-50 over which sperm will fertilize the egg, and that might dictate if the child inherits that gene mistake or mutation. So when it comes to analyzing someone to say, hey, listen, do you have any of these genetic mutations that you were born with? The way that we do that, and we call that germline testing, is through a saliva test. You know what, to be perfectly honest, it doesn't matter what I test. We like to test blood samples as well, but you have to be at a hospital or a center to do a blood sample. You can give a saliva sample at home. I could test eyebrows. I could test skin cells, but that would be a biopsy leaving a scar. It's messy. Easiest thing to do is to spit into a tube, send that off. There's enough of your DNA from your white blood cells and your skin cells for us to use to do this testing. Now, if you're born with a gene mutation, that gene mutation is present in every cell in your body, so it doesn't matter what we test. So for the sake of simplicity, we use saliva tests because it's easy for us to access this. If a gene mutation is present in someone's skin or white blood cells in their saliva, then I say, oh, okay, you were born with that gene mistake mutation. That may help us, if that person has prostate cancer, dictate their management. If we do genetic testing of someone's white blood cells or saliva cells, and we find no gene mistake or no gene mutation, then we say, well, maybe if you had prostate cancer, your prostate cancer happened by chance. It happened just by the natural progression of a healthy cell going rogue. And there's not this genetic predisposition that you inherited from mom or from dad. Now, the other way of us doing a genetic test is to just look at the affected tissue, the prostate cancer itself. We'll take a biopsy of the prostate cancer and test it, and we'll always find mutations there because cancers happen through normal cells with no mutations developing all these different types of mutations. And depending upon the mutations present, we may be able to do this specialized care. Now, this tissue testing is used by doctors to decide how we're going to manage you in terms of therapy. The germline testing can open up a whole bunch of different doors. It can help us with therapy. It can give us insight into, are you at risk for other gene mutations based on this finding? What about implications for family members now, children, siblings, parents, cousins? So there's two types, tissue testing or somatic testing and germline testing. So when it comes to testing, we can use, like I said before, blood, saliva, skin biopsies, doesn't matter. We use saliva because it's easiest. And basically people spit into a tube and then send that off to a laboratory and we get results back in a few weeks. Pretty simple process. It used to be very complicated, but nowadays we're doing a pretty good job in making things as simple as possible. So how does this impact someone? So looking at the typical kind of journey, we identify something like prostate cancer, oftentimes through screening, PSA testing. Sometimes it can be picked up because someone's symptomatic. And then we do a diagnostic test. Sometimes just a PSA can be diagnostic. Oftentimes a biopsy is required for us to identify prostate or say that someone has prostate cancer. At this point in time, we're set with a bunch of options for how we're going to manage active surveillance, radiation, surgery. And a man may pursue one option or the other. Man may be cured, or he may need to be retreated. And so the genetic story can actually help influence treatment choices. And so after someone's diagnosed, there might be a spot there for us to say, okay, well, let's see if this person has a genetic predisposition, and that may help us navigate what we should do. If this person has a gene mutation in a gene like BRCA1 or BRCA2, maybe they'd be eligible for using PARP inhibitors. If this person has a gene mutation in BRCA2, I know his prostate cancer is going to be more aggressive. Maybe he's not a good candidate for active surveillance. And if I was to do a treatment, maybe I'd be more inclined to do a prostatectomy so I could do a full pathology review of the prostate. And so these would be things that oncologists would want to start thinking about. And for us patients who have prostate cancer, another tool in our toolbox in terms of how we can help navigate our journey. So that's where people like me come in, genetic counselors. My job is to explain this whole process of genetic testing. We usually facilitate genetic testing. And nowadays, we're really on the back end. Once someone has a gene result or genetic test result, we can get in there and really talk about the implications of this for an individual, for the family. And so we try to kind of make sense of this kind of crazy genetic journey that a lot more people are going to. So one example, there's a couple examples that are out there of how genetic testing can kind of lead to more targeted therapies. And one of them is Angelina Jolie. Okay. I'm bringing up Angelina Jolie and I'm talking about prostate cancer. How does that make sense? It's really important, actually, because the same gene that she has, which is the BRCA1 gene, that increases her risk for breast cancer, which can be up to 80% lifetime risk for ovarian cancer. And the reason why she got testing is because her mother had ovarian cancer and was found to have this gene mutation. Well, Angelina Jolie did testing, found out that she had this gene mutation. And as a result, she took action. She had both breasts removed in reconstructive surgery. She had her ovaries removed, and she normalized this process for a lot of people. In Canada and the US, rates for genetic testing doubled and stayed that way after Angelina Jolie wrote her op-ed. She put these genes, BRCA1 and BRCA2, on people's radar. And as a result, we're seeing much higher rates of interest in having this genetic testing to help make medical decisions. For men, we don't do anything preventatively. We don't do any preventive surgeries or removals of the prostate when we see this. Instead, if men are found to have these gene mutations, they are at elevated risk, as Dr. Crawford said, for other cancers. For guys, I think about pancreatic cancer, prostate cancer, I think about male breast cancer. And so not just the prostate story, but there's a couple other cancers that we could be screening for and kind of get an edge on so that we're not caught necessarily by surprise. So how many prostate cancers actually have these gene mutations? What we know is that in men who have metastatic prostate cancer, that's prostate cancer that's spread, there's a study that came out in 2018 and showed 10% of men, a little bit more, of 12% of men who have metastatic prostate cancer have one of these gene mutations. And that's really important because men with metastatic prostate cancer, maybe at some point in time, they may be considering PARP inhibitors, and PARP inhibitors work in men with BRCA1, BRCA2, ATM mutations. People who have localized cancer, about 5%. And so by gaining this insight, we can kind of get an understanding of how to manage our risk, but also, at least through this PROMISE study, if any man has any stage of prostate cancer, they're eligible to get genetic testing done to see if they have any of these gene mistakes or mutations. Currently, today, we kind of do a one size fits all method when it comes to treatment. Every person gets that same treatment. Depending upon how they respond, we may react and do things differently. In this world of genetic, using genetic information, we may realize right up front, we can already move people in the directions of the best treatment for them based on their underlying genetics. And so the PROMISE registry is one way to help kind of create that future. I want to...
When I was diagnosed with...
Bring up James's story. I just want to double check that the audio is working for him. Did I get confirmation of that?
Prostate cancer. I was thrown into the process of, great. What do I do now?
Thank you.
So I went to my doctor and she said, let's look at your family history. And when she saw that data, she said, okay, that family history combined with the fact that you have prostate cancer, you really should have this test. When I got the results that I have the BRCA2 gene mutation, we reached out to both our daughters and explained to them why it would be a good idea for them to be tested. Both my daughters got tested. One was negative, one was positive. She knows what to do regarding each of the cancers that she is more susceptible to. And she recently said to me, Dad, I'm so glad I know because I feel more in control. To me, knowledge is power, and knowledge leads to better control and better decision making. There's been a shift in the healthcare field and in patients being active advocates for themselves, being a partner with their healthcare team. And I believe that's absolutely essential by drawing in lots and lots of men to the PROMISE registry. More rare mutations can be found and treatments can be targeted for those individuals. There's so much work for all of us to do so that people have the information to make informed decisions. So hope, I have deep hope.
So that was a James story. Let me see if I can exit full screen. There we go. To kind of give some sense of implications for family, implications for an individual, and really what we're trying to do and keep help research move in the direction towards.
When I was diagnosed.
So the PROMIS Registry, it stands for a Prostate Cancer Registry of Outcomes in Germline Mutations for Improved Survival and Treatment Effectiveness. Really, we have another good video that kind of talks more about the registry in and of itself, and I want to slide you to, and then I promise I'll stop with the videos.
Over 4 million American men are fighting prostate cancer. For many, the disease was written into their genes, but so are instructions to help us discover more about prostate cancer, how to treat it, and your own family's risk of developing the disease. That's why learning more about the genes of men with prostate cancer is so important. And it's why PROMIS was formed. PROMIS is a registry of prostate cancer patients who've joined a research study to advance knowledge about the role our genes can play in health outcomes. It's a collaboration between you, your doctor, and researchers from Johns Hopkins University and the University of Washington. We're asking prostate cancer patients to share their genetic information, their DNA. Your DNA could unlock knowledge about prostate cancer, guide the discovery of new ways to treat it, and help to predict your family's risk of developing it. PROMIS is completely free. Your information will only be used for research and will never be sold to a third party. And you don't have to leave your healthcare provider or even your house. Joining PROMIS is simple. 1. Get registered. Learn if PROMIS is right for you and register online. 2. Get the DNA kit. We'll send you a DNA test kit. A saliva sample is all we need. And 3. Get results. You'll receive information tailored to your DNA that helps you understand your disease better. Get started today.
So PROMIS in and of itself is our way of facilitating genetic testing, identifying information on individuals, and being able to use that to further research. If a group of men have a similar type of prostate cancer and they all carry the same genetic variant, what we may not have thought was significant, we may look back and say, have we just identified some other different aspect of this gene that we didn't otherwise think? Or could a group of men who get prostate cancer earlier in life, and they all had this same genetic variant in the gene BRCA2 or ATM, could we say, maybe we should be able to treat all men who have this gene mutation differently because of what we learned through understanding people's experiences who have this gene mutation? So we're looking to do new research that will increase precision medicine that helps in the fight against prostate cancer. We collaborate with physicians, genetics, patients, researchers, all trying to row in the same direction to be able to improve care and also gain insights, not just for our generation, but for the next generation. As the video kind of said, there are more than 4 million American men who are fighting prostate cancer. When we do a program like this, we'll be able to get a great, portion of people to participate. And what we want is for a big chunk of that to be men who are not of Caucasian ancestry. I'd like to have more people who are Black or Asian participate in these trials so that we have pretty even distribution and understanding of how these genes impact everybody, because we know there are these subtle differences. So really how this PROMIS registry works is individuals sign on, fill out a questionnaire, give some health insights. We send over a saliva kit that men can spit into a tube, essentially, send it back off, and then they get a genetic test result back. When they get the genetic test result back, they have a conversation with a genetic counselor. So should they choose, I always recommend that people do speak with a genetic counselor. to learn about how that genetic test result impacts them, family. Men who have gene mutations that are identified are eligible to participate. The genetic counseling piece of this, and this is something that Dr. Crawford kind of already brought attention to, but it helps do things that we've already kind of done, try to simplify some of these concepts of genetics and inherited risk for cancer. But it also gives us one-on-one time to ask questions and have questions answered. It empowers individuals to start making informed decisions about their own health. It gives us insight into the family to see whether or not women who share the same gene may have elevated risk for things like breast cancer. And maybe they need to start breast cancer screening earlier than someone in the general population. Or could also say, hey, if you have the gene mutation, maybe you don't pass it on to your son. And he's maybe exempt from this risk of cancer. And his cancer just is not elevated, it's just the general population risk. So we can gain these insights if we can understand why cancer happens. We can maybe start predicting who else is at risk and who's also not at risk. So with respect to this, registering online, providing a saliva sample, this can all be done from home. You keep your same doctor, everything's done for free. Benefits are that we get a genetic test result out of this. There's no need to meet any criteria. The only criteria is that you have prostate cancer. You get genetic counseling to describe what your result means in the context of your cancer story. Information that can impact treatment. As being part of this registry, we'll give you constant updates on prostate cancer, findings that we have from our research, as well as other research protocols that people could be eligible for. Ultimately, we're doing this to help further treatments and use this as a foundation to do more research studies. If you're interested in being involved and getting genetic testing done and signing up for the registry, we're at prostatecancerpromise.org. And that's all that I have to talk with you about today.
Thank you, Justin. And that's great. And I really like the way you went through it. And again, it's a very complicated topic, but I like this tag team approach because there are words that they've heard that you repeated. So I was always taught, tell them what you're going to tell them what you told them. So I believe that's what we basically told them. So I had a few questions that had come up. Okay, now I just wanted to accentuate something. Did you say that the test is free? Is that free with my insurance or just with some insurance involvement?
No, and so it's we have the funding to offer 5,000 genetic tests. Kind of a first come, first serve.
Okay. Well, that's important. So what you're trying to tell me is that it's free. I just want to repeat it again.
Yeah,
so,
yeah.
And men, Black men especially, and men who are at high risk should really be thinking about this.
Yeah, I mean, when it comes to, even now, a lot of criteria, for example, any man who has metastatic prostate cancer would be eligible to get testing like this done. But sometimes, the routes with which pursuing it can be confusing. This is a simple thing. You just get a test kit sent right to your home. You provide that saliva sample, you send it back, you get your result, you have a conversation with a genetic counselor about it, and then that gets integrated into your oncologist or treating physician has this new piece of insight for you that they didn't have before. It's that aspect of, being a bit of an advocate for yourself. If this isn't something that is already on your oncologist's radar, put it on their radar.
Now, so just to be clear, so what about do I need to contact my doctor, or does he or she have any say so? Or because sometimes it's very difficult. My doctors, the healthcare providers are kind of backlogged and it may take a long time. So is there any reason why they have to give approval or anything like that?
No, and so this is something that can be facilitated on someone's own. We just need To answer some of the medical questions, we'd like to know who the medical provider is. So that's optional information to provide. But we need confirmation that an individual has prostate cancer. That's our biggest kind of criteria for getting this process facilitated.
Now, are we talking about, well, what about people who are active surveillance, who have not yet been biopsied, but then may have a family history?
Yeah. And so if someone's on active surveillance and they have not been biopsied, then just notification of their PSA level. So when PSA gets to a certain level, then it's kind of enough for us to say, okay, well, based on your PSA, we can presume that there is prostate cancer, and that's why you're on active surveillance. And so that's enough insight that we need as well. There are criteria on our website for what we define as prostate cancer. And so if someone has any questions about that, I recommend popping into the frequently asked questions on our website. So,
okay, so frequently asked questions, but thank you. So we'll provide, since this is a video recording, so all this information will be available to our audience, and as we promote it, they'll have access to it too. Now, one thing that's very important, there's a lot of hoopla and concern about your genetic information. Now, is it safe?
Yep. And so the U.S. has the Genetic Non-Information or the Genetic Information Act. It's called GINA. And essentially what this does is it prevents health insurance from using this information against you in most employer insurance. Some of the caveats are that if there's certain companies that are under, I think, 35 individuals may not have the same protections. And then some life insurance companies, the Genetic Non-Discrimination Act may not have as much protections, but against health insurance that we are protected.
Okay, so it's free. Okay, and if I have prostate cancer, then I could take advantage of it, and I'm protected from insurance companies refusing to provide me health coverage. Okay, and then so that's, everything you say there is, why would you not get tested?
And so with this, I mean, we know that we're it's kind of like, as I said before, a first come, first serve. And we're interested in making sure that the people who are coming are those who we feel need to be more represented in the research community. The more people that we get, the faster we can start getting this wheel turning and start being involved and facilitating our own research studies. So the important piece to this is really identifying individuals who have gene mutations. Now, we're talking about those numbers. 10% of men with metastatic prostate cancer have a genetic mutation that increases their risk. 5% of guys with intermediate prostate cancer. These aren't huge numbers. And so of those 5,000 men, we're expecting to maybe have 500 who will be involved in our registry that we can start getting these insights from. But I also want to say that some people may already have a gene mutation. They may already recognize that. They may have already gone through genetic testing. And so these individuals can still participate in the PROMISE registry so that they can get access to other clinical trials that they could be eligible for, get access to research studies, get access to our newsletter that gives updates on what's going on in the community. But they would have to redo the testing process. So they may, one man may already say, yeah, I already have a BRCA2 gene mutation, but they would still do the same thing, register on the website. They would still get the saliva kit sent to them. It's spit into the saliva tube, send it off, and the genetic test would come back, would say BRCA2, and they'd say, yeah, I know. But now they're involved in the PROMISE registry.
But and there's something that's very important too, and I think just to highlight that is, at any time, the participant gives you approval to get information from your doctor. You just can't go out and just contact his doctor, right?
Absolutely not. And so everything is what's provided to us. And so it's totally up to the participant to kind of dictate which information we can access.
Now, I found that something that was important in my presentation, portion of the presentation, I was only I was talking about 8 to 13 different genes.
Yeah.
Now, I mean, that's not really a lot of genes. How many genes are you guys testing for?
Yeah. So we used to be testing for 30, but with our ever evolving landscape, now it's 29 different genes that are related to prostate cancer. Now, the reason why there's so many others is because there's still a lot that we don't know. And that's the reason why registries like this exist. Maybe some of these, there's on that list looking at RAD51C, RAD51D. You mentioned the gene HOXB13. And so, a new study just came out recently that said a common variant in HOXB13 increases risk for prostate cancer. But if that's seen very close to another variant, the risk for prostate cancer greatly increases. This study just came out a year and a half ago. And this would be something that we would include in our newsletters to say, hey, there's something new that needs to be on our radar. If you have a HOXB13 mutation, we also need to think about this other thing. And so it just keeps us on the pulse of what's going on in this ever-evolving field. We may find that a gene mutation that's super rare in one group is actually more common in another, but we won't know unless we test.
So it'll be important. I mean, I had mentioned before that you saw that disparity in genetic information. And I like the fact that you guys are kind of helping address the disparity by offering this free service. So I don't see heavy lifting. That's what I'm saying.
Yeah. And so we try to take as much of the heavy lifting and the process out of it. I mean, the challenge is signing in, putting in this information in your initial registration, reading through that consent form, signing off on that. And then it really gets easy from there on. And it's just that saliva sample and then we get that result back. And so we're trying to take some of the heavy lifting out of this process.
Okay. All right. And I had one last question. And who could take advantage of it? Just, is it all over the globe, or is it just New England, or who could take full advantage of this testing?
Yeah. Good question. Yeah. So anybody in the U.S. at this point in time. I'm Canadian, and so I would like to see some Canadians able to access this. But we're also, why not? If we're going to go international, why not have individuals from the UK, individuals from Europe also access? And so we're starting here because we want the representation. We want to be able to give insights to the American population, but ultimately we want to learn about these genes. And so they don't just impact people from the US, they impact people everywhere. But we're starting here.
Tom, did you have a question or?
Yeah, we have a few more questions from our audience. You mentioned that there was an effort to sequence the DNA of men, but they were primarily European background. Is there a similar effort to sequence the DNA of African American men? Also, how safe is my data if I submit my DNA to Promise?
Yeah, and so really good questions. So the effort to sequence, to test men of European background, there's this bias that we see within, medicine is that a lot of research studies we're seeing this gross over representation of individuals of Caucasian ancestry that doesn't match the representation that we see in community, in practice, in medicine. And so there's this intrinsic bias, and we would like to be able to address this. And so the reason why we're giving this talk is one of the reasons to do that. The same techniques, the same testing, the same sequencing applies to anybody. It's just that there's just been so fewer people of African American ancestry who have participated in research studies, and for reasons that are pretty complex.
Tom, I wanted to add on to something else too, and that was I remember I had mentioned that we did these complete sequencing of the human genome, and that was completed in 2003. But over the past 19 years, I mean, it costs billions of dollars to sequence one human. But now technology's evolved where there are areas where under $1,000, instead of having to sequence guests, people have the ability, and they're trying to approach under 500 places that will do a complete genome sequence, your own personal genome sequence, for under $500.
Yeah.
So it's not a need to have each person can now, or we're approaching it, hopefully, where it's like sub $200. So it's almost every person will have the ability to know specifically their complete genome, and we won't have to worry about trying to sequence, large numbers of African people, African ancestry or Asian ancestry or Spanish ancestry, because the prices to do that has dropped significantly.
Thank you, Dr. Crawford. Another question: how is PROMIS communicating with the men that participate in the study about how the study is going? Oftentimes, this is a comment, minorities are not made aware of what has been done with their samples.
Yeah, it's a really great question. And so we have a newsletter that we give out. I want to say it's monthly. I think it's maybe a few times a year. Essentially, what's being done with an individual sample is the generation of that genetic test result. Once we have that genetic test result, that's it. That's what the sample does, is it gives us that piece of paper that says whether or not we have a gene mutation and what gene mutation is present. The other pieces are then for us to be able to say, well, what does that mean in the context of your personal story with cancer? Are you on active surveillance? Have your prostate cancer upgraded and now we need treatment? Sometimes getting insight into someone's cancer story in the context of their gene mutation gives us additional insight. And so what we'll do is give newsletters on updates on how we're doing, how many men we have, and then we start doing research, publishing papers, summarizing that data so that we can translate what we've learned into something that the community can or participants can benefit from.
Now, to follow on that question, Mr. Lawrence, will each person who participates in the study receive their specific information about their test?
Yeah. And so each person who participates, you get your result back with your name on it. It's a medical document. And then that's for you to have. And then after that, we encourage, at least I encourage as a genetic counselor, individuals to meet with a genetic counselor, because having a piece of paper that says you have a CHEK2 mutation and it is a C.704, it gives you this kind of jargony result. It's always good to be able to say, okay, so what exactly does this mean? What exactly are my risks? And what is known about this gene? And what do we still need to figure out about it? A lot of these genes, there are still some question marks, and we won't learn what these genes do per se until we start studying the impacts of these genes on individuals. So yeah, to answer your question, you will definitely be getting your own personal report. That's kind of the foundation to being involved in this registry.
Right, and I think we might want to emphasize that, because I know with the PROMIS test, the patient does not have to go to the doctor as part of the initial process. So their doctor is not in that loop unless the patient chooses to provide that information or share that information with the doctor.
Yeah. Yeah.
So I think that's something you might want to kind of highlight and recommend, that once you get that paper back, go sit down with your doctor.
Yeah. And so the genetic counselors can also help with that. And I mean, that's exactly it. It's a piece of medical information that can help change someone's treatment. And so that's a very powerful tool potentially for someone to kind of take more of their cancer story into their own hands.
Okay, thank you. I did have someone that wanted to share the Task Force PSA project. Are you familiar with that project?
I'm not, no.
Net Healthcare Task Force PSA project.
No, I'm not, but I'm
okay.
Very interested.
Dr. Richard Hackner asked that question. Dr. Hackney, you want to know how can we partner? What I'll do is we will provide Mr. Lorenz's email address to you, and you all can communicate about that.
Yeah, I'd very value that. Thank you. Thank you very much.
Okay. Let's see. I did see something else. One is the service available to Black men in Canada.
Yeah, it's not available to anybody in Canada, and so I would love it to be. We're not international at this time, and so once we open the doors internationally, yeah, I mean, I'm gonna. There's an organization that I know of called the Walnut Foundation here in Toronto, and I'll just bang on their doors and let them know that this is up and running. And so once we do open it up internationally, then please know that we'll be talking and giving presentations like this to let people aware of that this opportunity exists.
So the answer to this question is that this service is not available to Black men in Canada at this time, but hopefully in the very near future.
So
another question. I'm sorry.
It's in the United States, but what about the Puerto Rico or territories, or are they located there?
Yeah, and so let me just I can clarify that right now. So Puerto Rico, Guam, American Samoa, U.S. Virgin Islands, Northern Mariana Islands.
Okay.
All the places where this is accessible.
And then another question is: do you have to be a cancer patient or survivor to participate in the PROMISE study?
You do, yes.
You do. Okay. All right.
But you don't have to have had surgery.
You do not have to have had surgery.
Or have had treatment. So there's this fine line. You could be on active surveillance, but depending on how high your PSA is, you may be able to participate.
Okay.
That's correct. And so let me see if I can give you the exact. Yeah, so PSA higher than 100, tissue biopsy, or radiographic evidence of prostate cancer.
Just to clarify that we may have to adjust for, you know how the deciliter versus microliter. So it may be a PSA of 1.
Yeah, sorry. Yeah, very good. Yeah. Nanograms per deciliter.
Okay.
Those are all the questions that I see, Dr. Crawford, Ms. Lorenz, from the audience. So do you all have anything that you would like to share with our audience before we move on to our next step in our program?
I just want to thank you for giving me, the opportunity to speak. It's an honor and a privilege to be able to share this information and to have you as an audience for this talk. And so thank you very much.
Ms. Lorenz, thank you so much for being our speaker this evening. Great presentation. I'm sure very beneficial to those who tune in. And Dr. Crawford, as always, the number of comments about how your presentation helped people understand some of these complicated terms. So thank you, Dr. Crawford, and thank you, Mr. Lorenz, for your presentation.
Yeah.
Now, I would like to say to the audience, it is time for you to give us your feedback with our survey. So, Jerry, can you release the poll, and you will see in front of you survey questions. There are 10 questions, and I think they are pretty straightforward. So please take the time to answer these for us. And as I said at the beginning, they will really help us better understand how to make our programs more effective for you. So I will, while you're completing that, I would just like to say that PHEN has a number of programs that are ongoing. And we our 18th annual African American Prostate Cancer Disparity Summit will kick off on September the 7th. And so I want you to be aware of that. Mark that date, mark those dates as September the 7th. Our first session will be 2.5 hours, September the 14th, 21st, and 28th. 4 virtual sessions for our 18th annual African American Prostate Cancer Disparity Summit. So please mark your calendars for those. Also, we are launching our 3rd African American Prostate Cancer Disparity Rally in South Carolina next week. So we will begin that program next week in South Carolina. We completed our rally this year in North Carolina and in Georgia. So South Carolina is next up. So you will be hearing about that. And we will have our disparity rally virtual town hall meeting on August the 18th. So on August the 18th, we will bring together many of the participants who participated by voice and messages across the state of South Carolina on radio stations in Charleston, Columbia, and Greenville. So again, mark that on your calendar at 6 p.m. on August the 18th, our virtual South Carolina town hall meeting from our disparity rally. So those are the things that, we enjoy very much putting together these programs. We get good feedback from our viewers. So we're making an impact. We can make more impact with your participation. And we certainly appreciate it as we move along during 2022. Now I do see that we're getting some good feedback from our survey. It is not closed. We've been online with a survey now for 3 minutes, a little over 3 minutes. We typically like to let this run for about 15 minutes so we can get as many people as possible and give them the benefit to raise their voices through the survey.
Tom, I wanted to kind of highlight some stuff just so everybody remembers this, that it's interesting. We talk about this disparity that exists. This Promise Registry kind of removes some of the bottlenecks associated with getting the kit. 1, it's free. 2, you're not giving blood. Now, this is sputum. And we know that a lot of the primary care doctors are just kind of busy and they really don't have the time to hunt, fill out paperwork and all this orders and worried about the insurance reimbursement. But I think Promise has done an excellent job at addressing some of the major hurdles that take place. And so I just wanted to highlight that if we have this massive disparity that exists in the amount of samples that have been tested for Black men, I mean, this study, Justin said, 5,000, they're looking at 5,000 people, and there's a lot of space left. So this is something that everyone should really take full advantage of, especially since it's free.
Thank you, Dr. Crawford. We've a couple of additional questions have been submitted. Once one has received a genetic evaluation, how often is it necessary to identify further changes? That's an interesting question.
Yeah, it's a really good question, actually. So whenever they do, I mean, to go back to Dr. Crawford's analogy of it being like a cookbook and recipes. So the cookbook has been written in red. The recipes are there. one of the interesting things about genetics is that we only know what we know today.
That's right.
But if we learn something new about some of these genetic mutations in the future, we can apply that knowledge to a past test. So what I like to say is that, when we do a test like this, we find lots of different mutations. We're testing for 30 genes. We're going to find maybe 40 different mutations. Most of these mutations are non-problematic. They're just normal variation. And they're things that everybody's going to have some of these. Most mutations actually don't cause problems. Very few mutations actually make a gene not work or cause a medical outcome. And so we classify mutations as benign, non-problematic, uncertain, and problematic or pathogenic. And so there could be fluctuation. Maybe a mutation that we thought was benign gets upgraded to being uncertain, or maybe a mutation that's uncertain can get upgraded to being problematic based on new research that's done. And so the test itself doesn't need to be redone, but it could be reinterpreted based on what we know in the next years. And so could get a result in the mail and say, hey, listen, remember how we thought that you had an uncertain result? Well, actually now it is problematic. And that would change things for that individual.
Thank you. Another question. What about someone newly diagnosed? And I think you've answered that. All men who have been diagnosed with prostate cancer are eligible. Then another question is, where do we get the tests?
Where?
How can you tell us again where to sign up for testing?
Yeah. And so the website is prostatecancerpromise.org. And when you pop in there, you fill out that registration, fill out the consent form, and then the test gets shipped to your home.
Yes, and that link will be on PHEN's website. So you can go to our website and sign up right from our website.
Right. And you said, and I'm just typing it in the Q&A section. You said prostatecancer.org, correct? Oh, I lost you for a second.
Yeah, sorry. Prostatecancerpromise.org.
Okay. So, Jared, let's kind of close the survey. Right. So we had 15 people, it appears, who responded, and we will kind of walk down through where we are. Do you understand what genetic testing is? We had 80% affirmative, 1 says no, and 2 that need more information. Again, I will encourage you to go back and view Dr. Crawford's presentation and Dr. Lorentz's presentation. This whole program will be on PHEN's website within the next week or 2. So it will be available, and you will be able to kind of flip through and go through this and get any information that you may feel that you didn't understand. A genetic test is strongly recommended for Black men and high-risk men. Yes. So I think that message came across pretty clear to our viewers. One need more information. Again, I would recommend that you view this presentation again. Is an inherited mutation the same as germline mutation? 7 said yes, and 5 said no, and 3 said I don't know. Is inherited mutation the same as germline mutation? Dr. Crawford, let's clear that up right here.
Yeah. Yes. So that's what I wanted to make sure that everyone understood, that if it's a germline mutation, germline, think of genes, and line, think of your lineage. And so when you think of that, that's your inherited genes. That's an analogy that I'm using. So it is the same. So it's inherited mutations and germline mutations are basically the same.
Okay. Thank you, Dr. Crawford.
You're separating that from somatic, which is not inherited or not passed on to your children.
Thank you, Dr. Crawford. And I trust that everyone heard that explanation. So to answer that question, is an inherited mutation same as germline mutation? The answer is yes. Do you now understand the difference between germline mutation and somatic mutation? And I will refer back to Dr. Crawford's answer to the previous question. Do you feel that genetic testing could be a future benefit to you or a loved one? So I think that message came across pretty clear, 100%. Very good. Would you consider participating or refer someone to the PROMISE clinical trial? 87% said yes, 7% said no, 7% I need more information. The presentation and discussion were excellent, 87% good, 13%. So those are both positive. So thank you. And again, I want to thank Dr. Crawford and Mr. Lorenz. The response to questions from the online audience were excellent, good. So again, thank you for the clarity in responding to the audience questions. And that's a good score. Many times, and this is an area that oftentimes we will see not a score not as high as 80%. But I'm pleased to see that the audience felt that we addressed their questions thoroughly. Overall, how satisfied were you with the webinar? We got 87% very satisfied and 13% satisfied. How likely is it that you will recommend this webinar to others? And we 100% said very likely. So yay. Yeah. So again, I applaud our presenters. And what I would like to do, I would like to end this program by again saying thank you to our audience, thank you to our presenters, and thank you to our sponsors for making this program possible. And with that, I would like to say good night, and we will see you at the next PHEN event.
All right. Thank you.